We've got pre-notification a 40-year-old male has been stabbed in the chest over the cardiac silhouette. Odds on, might have a tamponade. It's thoracotomy.
One of the best things for thoracotomy training is to really have this unfamiliar situation become familiar. So it's about really breaking it down into clear indication, but then really having a shared understanding of what the procedure involves.
Hi, it's Jonathan.
Hi, I'm Emma.
And this is Cut to the Case. And Emma, I've got a case.
Okay, go ahead, Jonathan.
I've got something that happened the other night, and it's thoracotomy. So I thought we could talk about thoracotomy, but we could talk about the teaching and how you get people on board with thoracotomy.
Great. Well, tell me the case.
So the case, so cut to the case is what you're saying.
Yes.
So we've got pre-notification a 40-year-old male has been stabbed in the chest, and we're hearing it's one single stab wound over the cardiac silhouette. Odds on, might have a tamponade. The story is a heart rate of 130, and he's got an unrecordable blood pressure, but he's got signs of life. He's still talking to them, so he hasn't arrested. Yeah. And they're not saying he's got a pneumothorax, they're just saying he's got a single stab to the chest and he's shocked. Okay. So we set up a team, and my role in the team is not to lead it, but to do procedures. And I'm asked to do procedures on the patient's right-hand side. So I'm not on the normal thoracotomy side. And I'm scrubbed, ready to go. And I'm going to do vascular access. And maybe decompress the chest on that side. And the patient's about to come in, and we've done a team brief and we're talking about what to do. And then I sort of looked across to the doctors who were going to do the thoracotomy, and then it struck me, I don't know them. And I don't know how confident and capable they are to do the thoracotomy. Okay,
so you don't really have a shared understanding.
That's it.
Okay.
Yeah. And I thought we could talk about what do you do in that situation.
Yeah, okay. Well, why don't we first talk about pre-brief, so that sort of time before the patient arrives. How can you set that team up better so that you do know, one, who they are, their names, and their capability of being able to perform a thoracotomy?
Well, we can do a one-team debrief. We can do a one-team debrief. Obviously, ascertain, get the names, introduce yourself, where are you from, what do you do, and then probably an outline of what we're expecting, and a plan A and a plan B. And then usually I would ask them, so when you're in this role, what will you do when the patient comes in? So, and I'll get them to run through what they'll do. And then hopefully we'll get a shared understanding, and I'll get some gauge on how comfortable and capable they are.
Okay, that sounds great. That sounds like the beginning of that shared understanding. So should we digress for just a minute?
We could.
And really look at the indications for ED thoracotomy. Do you want to quickly run through those, Jonathan?
Let's do it. So my understanding
Your understanding.
So my understanding. No, also, well, let's put it out there. There are differences in survival rates quoted by different people in different countries. And that affects the indications, but our indications are, so someone who's arrested within 10 minutes or arrested in front of you and has a pericardial tamponade on ultrasound. So that
Visible
would be
on ultrasound.
That would be main indication. And the second indication is someone who is profoundly shocked, so low blood pressure, so less than 70, but you've resuscitated them, so you've given them a MEP, or you've given them one-to-one transfusion, and you've decompressed the chest. And they've got a tamponade. So in someone in that situation, that's an indication for a thoracotomy.
So what you've just done there is really outlined your understanding. And as I'm listening through your indications, I'm also ticking off, that actually matches my understanding.
Well, that's good.
And that gives us the opportunity so that if my understanding is different to yours, we can correct it. So I guess that's the whole idea behind having a conversation around shared understanding. And so one of the best things for thoracotomy training is to really have this unfamiliar situation become familiar. So it's about investing in teams and training in teams and really breaking it down into clear indications, as we just went through, but then really having a shared understanding of what the procedure involves. So we'll put up the 7-step procedure. The reason behind having this simple method is it allows you to do mental rehearsal. Jonathan, can I ask you, do you ever do mental rehearsal in the car on the way to work?
Well, I'm in the train these days, so
it's
I
free.
Can do. It's free. No, I do. But like in this situation, in this case, I was actually doing the mental rehearsal. Because you know why? I had nothing to do. So I'm sitting there scrubbed on the other side, thinking, okay, what am I going to do when the patient comes in? What would I actually do? And I find that's actually so powerful that sometimes I think I've actually done the procedure when I haven't actually done it because I've done the mental rehearsal. So I don't know whether you do that.
In the words of one of my colleagues, never go where your mind hasn't already been. And so that's one of the powers of mental rehearsal.
Yeah,
and
good.
So when I'm thinking about the thoracotomy, I'm going through things like make the incision, and I need to know the location, and it's the same area that you're going in for your chest decompression, so the fifth intercostal space. And I'm just making that incision. Then I'm spreading the ribs. Clearly there's lots more layers in this, but these are the main steps that I'm going through. Spreading the ribs with your rib spreaders, with the handle up in the axilla, packing away the lung, opening the pericardium, delivering the heart, identify and control any injury, and then maintaining control until you can get to theatre with either a cardiothoracic surgeon or a trauma surgeon. So they're the 7 steps, but breaking them down into something that your mind can mentally rehearse means that my understanding can be shared with you, with the team leader, with the airway doctor, with the procedure nurse, and we've all got a shared understanding of what needs to happen in this highly critical procedure.
So really what, and I guess we didn't run through the 7 steps in this case. We didn't have to do it. Right? We didn't run through it, but we did share the model about the indications and why we would do it. But that's a great sort of concept. So I could have run across the other side and said, hey guys, if we did do the thoracotomy, here are the steps that we'd go through. And maybe when you're actually doing it, just call them out, let me know so I know what you're up to.
I'm spreading the ribs.
Yeah, I'm spreading the ribs.
I'm retracting the lung.
Yeah, and so
I'm opening the pericardium.
If something's not working or it's not going the way we expect, we can help each other.
Yeah.
And so we're on the same page.
Yeah.
So I love the 7 steps.
Well, what we do in our training is we clearly go through some task work training. So on a part task trainer, we're doing the 7 steps. This is the model you've made, Emma.
Yeah, come on. And we will show this.
In my shed. I don't have a shed, but
we will show this model. And look out, there's a video coming. We're going to make the video of Emma doing the thoracotomy, but with the 7 steps.
But essentially, it's there's the proceduralist, but there's also the assistant. There's also the scrub nurse. So they also need to have a shared mental model. But then there's other roles within the room. So there's the airway doctor and nurse, and they need to have key steps identified in terms of when they've intubated the patient, ventilating the patient. They need to anticipate perhaps a return of blood pressure if indeed the tamponade is reversed. But the team leader also has some steps. And so the way that we train our doctors is we rotate them through all of those roles. And that's really important for an ED team, because as an ED doctor, you might be team leader, you might be airway doctor, you might be a procedure assistant, you might be the proceduralist. But understanding all the key points of each role is really important, and it allows repetition, because repetition really helps for these halo procedures.
And as we've said, it's probably, I don't know how many you've done, but it's something you don't do very often. But the mental rehearsal has kind of built it into your memory, so you think you've done it.
Yeah.
So, and I think I've done the airway role on that, and I think I've done the helper role on that, and I think I've done the actual cutting role on that, and I've done the leadership role on that. So I think I've sort of done it. So when it actually happens, I'm comfortable to do any of those roles.
Yeah, good. Yeah. So I guess there's some key learning, and that key learning is really about trying to get some simplified ways of teaching halo procedures and combining your sort of teamwork communication with your task work. So back to your case, Jonathan. How did it go?
So what happened was we had the briefing, as we said. The patient came in. Blood pressure was not recordable initially, but when they came in, they'd already had 2 units of blood. He was actually talking to us. He looked really unwell.
Yeah.
Blood pressure was 85, and there was nothing else to find. So he didn't have signs of a tension pneumothorax. It was right in the middle of the cardiac box.
Did he have a tamponade?
And he had a tamponade.
Okay.
So he had a tamponade with a blood pressure of 85, and he was looking okay. So he was looking like he didn't need an ED thoracotomy. But I tell you what,
he didn't meet indications.
He didn't meet indications, but I tell you what, we were ready to go at any moment. So fortunately, we were able to do an OPSTAT.
Straight to
theatre. Well, it wasn't straight to theatre, but it was pretty well straight to theatre. We were able to get him up to theatre where cardiothoracics were able to do the thoracotomy. and it's a happy ending.
Great.
But for a while, as we were waiting, preparing, there was just that anxiety moment. Well, if the blood pressure is going to be 70 or sub 70 or arrest, what are we going to do?
Yep. Prepare for the worst,
Yep.
and that's your chance of making your outcomes as best as they can be.
Yeah.
So great. So
Yep.
you had that clear moment of he
Yep.
doesn't meet our indications,
Yes.
which he'd shared,
Yep.
and he was able to go up
Yeah,
to
and
theatre.
it was all nicely shared. So everyone was quite happy with the outcome and the way it worked. And I think truly, if it was that he were to arrest in ED, we were ready to go.
Yeah.
Yeah, we
Good.
were fine. Stab in the right ventricle, as the pathology usually is, and he's done fine.
Yeah.
Yeah.
Great.
All right.
Shared knowledge and
So-
shared understanding. Love it.
I love your catchphrases, Emma. So look out for the thoracotomy video,
Yeah.
because that's coming. All right. See you, everyone.
See you, everyone.
Bye.
Bye.